All right. Good morning, everybody. So thank you all for coming. We've got a crowd of 400 plus a wait list, plus people who just showed up because they heard there was good food and awesome speakers. Probably in that order. So thank you very, very much for joining us today. We've got a very full slate of panelists, very thoughtful on their topics. But the first thing we'd like to do is have an opportunity for Matthew, representing Longwoods, to say a few words.
Morning. Very quickly, Breakfast with the Chiefs, we've been running for over 15 years, and these events would not be possible without the support of our sponsors. So I'd like to just quickly thank our sponsors, the Canadian Foundation for Healthcare Improvement, IBM, HEROC, Low Barnes Consulting, the Canadian Institute for Health Information, PwC, and Cerner, and of course Rotman for providing the facility today. Thank you.
So next I'd like to have an opportunity for our host, Brian Golden, to say a few words. Many of you will know Brian, and far more than just being our host today. Brian has had an instrumental role in many aspects of healthcare, and one of his most important contributions has been facilitating and participating in what is often called the Baker-Price report. But when you actually get the Baker-Price report, and you take a look at the very front cover, what you see are actually two other really important names who participated in that process, who really helped bring that report to life. And one of those is Brian, and actually the others is Rosemary, who I saw here today. So Rosemary's also, there she is at the back. And Rosemary and Brian, along with myself and several other people who are here today, supported our chairs, David Price, who's here speaking today. And so it was more than appropriate that Brian volunteered his time and his space today to host us and to say a few words. Thank you, Brian.
So welcome to Rotman, everyone, and thank you, Joshua. So one of the things that was most interesting about the work we did was we were regularly having conversations in our work on primary care, which was the focus of our committee, around home care, around public health, around the role of the LHINs. So it has been great to be offering up this space and supporting this conversation today. It's a critically important conversation. And David has been a pleasure to work with. I would just say when we were finalizing the initial report, we did a coin toss around authorship. And I did not win. I've often been thankful for not having won. And I learned that you don't flip a coin with a doctor over the phone. If he's flipping it. This is, as I say, a critically important conversation with all parts of where we need to go in the health system. So my hope is that we have a wonderful conversation this morning and that we move very quickly from a conversation to much more substantial action. We've had a lot of conversations. The next actions will be informed by the work of all of these folks. So I'm looking forward to that. I'll just remind you of one rule at Rotman. If your phone goes off in the middle of class, you've got to buy the group champagne. It's a big group. So Joshua, all yours.
Whenever Brian says that, I immediately try to phone him. So when I first saw the patient's first paper, I was sort of struck by its breadth. I'd been on the sort of Baker-Price panel, and I knew that primary care would sort of be involved. And then I had the privilege of reading Gail's paper, and I sort of had a feeling that home care might come to play in this. And then I'd actually had a few minutes with the minister after he spoke at our health quality transformation. We were walking, taking the escalator up, and he said, public health is really important. I don't think we knew enough about public health. And as we think forward, I think public health, I thought, wow, we got public health. And I think very early on, the deputy in his tenure had come down and had very publicly said in many settings, you know what, we're going to double down on the LHINs. We're going to double down on the LHINs. It became one of his speaking points early on. And so when you read the patient's first document, you really realize just the breadth of the potential structural process and cultural transformation that is being proposed in that document. And 2 weeks ago, there was actually a breakfast with the chiefs, again sponsored by Longwoods over at Mount Sinai Hospital, in which the deputy gave a very thoughtful and broad sort of insight into the paper as a whole. And what I sort of envisioned for today was a bit of a deep dive. A bit of a deeper dive into each aspect of what really will be fundamentally sort of potentially transformed, depending, as Brian talks to, the actions that are taken after today. And so we have before us a set of panelists who really have a lot of knowledge and expertise in their particular area. And we are also joined ultimately by perhaps the most important voice in this document and in the healthcare system, which is Crystal Chen, and a voice of the patient. And in fact, in the initial release of this breakfast, we were a failure, really, on my part, to be honest, of not having been clear about a voice of the patient. And immediately, angry emails started to fly and said, you know, where's your voice of the patient? And Crystal very kindly has joined us today as perhaps the most important voice in a document called Patients First and in any transformation of the healthcare system. So what we thought we'd do today is hear from each of the panelists, and then a respondent from Crystal. And what I've done is I've asked them to answer 2 questions. I have to actually remember what exactly I asked. I haven't changed it, don't worry. Where are you going on your summer vacation? Yeah. And are you taking me? The questions actually that I asked is, what would you hope to see different in your respective area of expertise and leadership in 3 years if Patients First is successful? And what would be the key success factors in the next 12 months to get us there? So each of these speakers will speak for no more than 10 minutes on that topic. Krista will then provide a respondent perspective from the view of the patient. And at that point, Brian will also give a couple sort of responsive thoughts before we open it up to questions. So that is the course for the day. I will be ruthless in my timing. Ruthless, I warn you, ruthless. And I think with no particular pre-planned order or anything, we'll just start at the far end. As I invite David Price up, I will sort of recognize Susan Fitzpatrick, who is our local Toronto Central LHIN CEO. She is actually hosting tonight a series of consultations with primary care. I believe the one tonight is at St. Joe's Hospital, if my memory is correct. I know because I've been asked to cover clinic for somebody else so they can go and talk to Susan. So if there's any primary care providers, please join Susan tonight. All yours.
Thank you, Josh, and thank you very much for having me here. Brian, you didn't lose anything, actually. Where are you, Brian? We had Family Medicine Forum, which is a collection of all the family physicians, or it's a conference of about 5,000 family physicians in November, and one of my colleagues came up to me from, a colleague from Saskatchewan came up to me and said, so David, what's it like to be the most hated family doc in all of Ontario? I said, well, so we're going to call it the Golden Report. So thank you, Josh. And this is an interesting challenge to try and distill where we want to be in three years. And I thought I would give 3 very, very brief stories. The first is one of my administrative assistants who came to me just before Christmas and said, David, my daughter just moved to more rural Ontario. She has an 18-month-old who needs her 18-month-old shots. Her husband has phoned every single family physician within a 40-minute drive of where they're living, and not one doctor will take them. This has got to be a failure of our system here in Ontario, and actually, frankly, it's a failure of our system in Canada. If you move with your child, we put the child in school. How on earth is it that we can say, as a collective, that we don't provide that kind of care for individuals? I know folks have heard me say that before, but hopefully that is where we're moving towards in the next 3 years. And it may be that we have to do things differently, and that is one of the key aspects of this is in terms of leadership, is it has to be leadership from our family physicians, from our clinicians, our nurse practitioner colleagues, our pharmacists, et cetera, and all of the healthcare team, including the administrative aspects of it, to say, how on earth is it that we provide the kind of care that we want, and how do we do it differently? The second story is of are patients who they vote with their feet. They go to where their care is most convenient, where it's accessible, and where they get it in a timely fashion. I was talking to one of my walk-in doctor colleagues, and he saw 107 patients in just under 10 hours. That's got to be terrible care that we're providing, but why is he there? He's there because there's a need, and he drove it through. But there was no integration, there was no collaboration with those patients' primary care system. I know this fellow, he's an excellent family physician, and he's doing this as a sideline. But we've kind of created the system where he's not able to deliver the kind of integrated, coordinated care that we as patients need. My third story is that we certainly have a system that works in many aspects. My wife had major cardiac surgery here in Toronto because Hamilton, which does 10,000 open heart surgeries a year, wasn't a big enough center for her to have that work. And the care that she had at UHN was outstanding. I can't say enough about the cardiovascular ICU where she spent almost 10 days. But what was really apparent to me was when she was discharged, she got pushed down that bridge between the hospital and primary care, and it was a rickety old bridge. And thank goodness I had the connections to phone the vice president of the hospital and say, how on earth is it that there's no coordination? And so that's my wish for 3 years, is that we have a coordinated, integrated system whereby there's communication between the various sectors. And that is what we don't have. We have family doctors who are incredibly focused and considerate about their patients. But when I talk to them, they tend not to look broadly about their patients within the system, because that's not what we train them for. That's not what we created the system for. And that is our real challenge, is how do we start to think about them working within an integrated, holistic system? And so that's where I hope we can get to in 3 years. If you ask me, what are the barriers over the next couple of years, I'll go back to a quote that's a Latin quote, and it's fortune favors the bold. And my concern when we look at our Patients First document and what we're doing here, both in Ontario and across Canada, is we're taking tiny steps. We're not perhaps seizing and going the whole way. And that's what this Patients First document, if it's realized, has a potential for us to do. If we can actually move our system broadly towards it, it's not going to be perfect. It can't be driven by the government or the ministry. We can't say to the whole province, this is how you're going to do it. We need to set out what the accountabilities are, what the frameworks are, and allow the local leadership, whether that's the LHINs, whether that's the family health teams, whether it's the nurse practitioner-led clinics, the CHCs, it doesn't really matter. That's the local leadership, and we have to enable that local leadership. So I'm happy to talk further about it, and I would just want to acknowledge that some of those ideas and some of the concepts are from a very large group of people, and one of the wonderful things that I get to do is be the recipient of a lot of feedback and try to distill it. So you can shoot the messenger if you like. Thank you.
So next, I think we'll ask Gary to come forward. We have at least one of your colleagues here, and so Gary, welcome. Gary, I think, is one of the longer-standing LHIN CEO members and has been very instrumental in moving forward Patients First. Thanks for joining us.
Thank you, Josh. And I am the CEO of Erie St. Clair LHIN, which is Southwest Ontario, the real Southwest, and it's also the gateway to Ontario. I'm going to dive a bit deeper on this one because we're closer to the delivery systems as a LHIN now, and I'll give you our idea of what it's going to look like in 3 years. Starting with the patient's perspective. Every resident is going to be rostered with a primary care provider. If they opt out, we will know. If they need to stay with their provider in another LHIN, we'll make that work, or in another sub-LHIN area. They will know how to access care. It's not necessarily having access to their physician at the time they want, but possibly to one of the allied health workers or a nurse practitioner within that office or within a clinic that's connected to it. We will have a health human resources plan for our physicians. Right now, I cannot tell you how many primary care providers we have in Erie St. Clair. Can't tell you. Can't tell you the roster size, can't tell you where they work, how they work. That's got to change within 3 years. Care navigation and case management will be provided in primary care and in our acute and post-acute. It may be virtual or it may be resources in their organizations. Better access to specialty services. Talked about consultation with primary care. We've done a couple so far, and it comes out loud and clear. You want to create capacity in primary care? You want to improve care? Give us better access to our specialty services. So with eAssist and eConsult, we should be well on our way. Greater self-management tools, and I'll talk about that later because we have great projects going on in our LHIN with self-management processes. Patient will also see greater community capacity in their community within their sub-LHIN on volunteers helping the community. There's been great work done led by hospice on community impact on doing that. We have 700 volunteers mobilized in Windsor, Essex to assist that way. From the public's perspective, they'll recognize the role of the LHIN has shifted. They'll have access to what the health of their population is in their sub-LHIN area. So that's pretty cool. When you look at a small community like Petrolia, in their catchment area around 30,000 people, that's quite manageable to reach that population with the caregivers and produce the evidence for them to show them what the health of their population is. Now, what goes with that is, now that you know the health of the population, you better be doing something about it. So the LHINs should be held accountable by the public for that. From the stakeholder, greater capacity in primary care through having the navigator and case management accessible to their office and also in the acute and subacute world. We're going to continue to roll out our high user utilization management tools within every sub-LHIN. Bundled payment strategies will be alive and well. Lateral accountability will be established by the governors within each sub-LHIN area. Right now, we're dealing with a world where individual providers have fiduciary responsibility to their corporation and not to the system. That makes our job pretty hard when a community board wants to balance their budget as opposed to doing what's right for the system. We are moving towards shifting that. From the system perspective, population health planning will be inclusive with our public health partners, starting with prevention. Leadership tables will be established to go way beyond healthcare. We will have housing there, we will have court services there, we will have education at those tables. Everybody's responsible for population health. And it's our job as local leaders to facilitate that. System funding needs to shift to sub-LHIN strategies as opposed to individual corporations. And within 3 years' time, I truly hope that we have the ability, and where's Nancy? Hi, Nancy. To be able to manage the funding within a sub-LHIN area, and if we need to close an acute care bed to open up 2 assisted living beds, we need to do that for that population. Getting there from here is going to be a challenge, but it's definitely something that I see out there. With respect to the first 12 months, the Chinese have a proverb. They say there's only 2 good times to plant a tree. The best time is 20 years ago. The second best is today. So these changes that we're talking about, everybody's known about them. So let me tell you what we're doing, and we're doing this without legislation. What we've replaced the legislation with is the patient. So we're working on this on our high utilization. And we got a great project going on with Chatham-Kent with 2 significant partners, MedGPS and NextJ. And we've identified these high users, and we bring the data to our 3 family health teams. And the physicians look at this and go, I didn't know this patient A has presented 12 times in the emergency department for 107 days in the last 8 months. I didn't know. And now that I know, I want to provide better care. And then you sit CCAC down beside them and say, really? We have 8 different services going in? And they didn't even know. People walk beside each other not knowing. We need to fix that in the next 12 months. And so we're going to continue rolling out our high utilization management plan right across the system. We're funded for Sarnia and Lambton this year. That'll give us 2 significant counties. I need funding for the 3rd county to be the first region in Ontario to have a system view of utilization. Getting back to sharing that evidence, I always say transparency is the new currency. Transparency will bring providers to the table to improve care. Once you have that data and having real-time data, we're starting to get the results from it. And we're also testing the proof of concept. We have the University of Windsor involved to assist us in a third-party review to demonstrate the proof of concept and to assist us in scaling this. Next 12 months, our sub-LHIN framework is going to be very well established. It'll be clearly defined and understood within each sub-LHIN area by the population there and by the stakeholders. With that population profile and segmentation, we will have the risks identified. I was talking to Camille earlier about equity. Once we know in a sub-LHIN area that the population on the east side of the bridge in Windsor is significantly different with outcomes than the west side, we better do something about it. And within the next 12 months, we need to identify those gaps and put strategies in place to close it. Partnerships. Population health does not reside in one organization, as I said. We need leadership tables established across the broad community with business leaders, education, court services, to help assist in defining what we need to improve the delivery of care and the transitions of care in those communities. We need to be supported by strong governance. Our board, we're supposed to have 9 members on our board. We had 9 members for a total of 8 months, 10 years. We need to fix our governance structure, and we need to educate them for this new level of responsibility, and we need a strategy for the next 12 months in order to do that. With respect to our governors and the leaders of our health service providers, they need to move closer to greater collaboration for lead agencies, and I would hope accountable care organizations. In the background, it goes without saying, contracts must be modernized. If you think that these changes can occur just by moving it over to the LHINs, as my chair says, all that does is put the laser on us. If we think that we can improve it without making structural changes to the delivery system, we're fooling ourselves. We need a provincial transition team to ensure that this happens. There's up to 6,000 employees, I think, involved in the CCAC alone, never mind primary care contracts and then our partners of public health. We need to change the culture to have a more patient-focused culture. We need to deliver on our new brand promise to support what's in the patients first. So a lot of good work, and I usually say at the beginning of every talk, every day is a great day to be in healthcare, and today is a great example of that because we're talking about a significant change that is more significant than the introduction of LHINs 10 years ago. Thank you.
Well, that was a bit of a throwdown there, okay? So lots of frantic note-taking. So our next panelist is Gail. Gail has had so many important roles in healthcare. One of the latest is with a very small but mighty group. She led a very transformative set of recommendations for home care, which sort of are imbued throughout the Patients First document. I think shortly after Patients First came out, very much echoing Gail's report, there was a columnist who called this one of the most transformative changes in home care in well over a decade. So again, Gail, congratulations to your leadership. Thank you.
Thanks, Joshua. Good morning, everyone. I'm glad to be here and to add a home and community perspective that's probably more my perspective on what we need to do now and going forward. I'm going to also try to be really brief. But I think when we hear the words patient first right now, we think about the most recent discussion paper, and I think the deadline for submissions is next week, so hopefully all of you have put your comments forward. But actually the Patients First label began really shortly after my mighty group, and I submitted to the Minister of Health the Bringing Care Home report. And then after that, the Minister tabled the Patients First agenda, a 10-point plan, a roadmap, etc., the Auditor General's report, and now the discussion papers. So I think it's all those things, along with David's paper, that are forming the kind of backdrop for what we're seeing now. What I want to talk about, though, is what needs to happen to improve care. So I really want to talk about why are we doing all of this, and it really isn't to have a structure unless that structure changes how we do things. Particularly, my interest is in home and community. So I'll try to focus on the questions Josh asked, but not on the vacation questions, because I at least know the answer to the second question was no, you can't come. But I think you need to know, I take the term patients first quite literally. In bringing care home, we talked about the family as a unit of care. And family, by family, we're not meaning people who are necessarily capital F family, but whoever a client considers to be their family, could be the neighbor. Because I think what we can't forget is arguably 75% of care at home is provided by unpaid people. Family, neighbors, friends, etc. And so we need to keep that foremost in our minds. So when you say families are at the center, you change many, many things, but mostly you're changing the culture of how we do things now. So that's where I'm headed. So I think the minister's roadmap and the bringing care home and the discussion paper to a certain extent have a lot of goals in common. Issues of consistency, transparency, we've heard these already, accountability, access is both to care and to information, so communication. We want to be needs and outcomes based. We've heard that this morning. And my whole pitch today is restructuring, which is what the most recent discussion paper is about, is a complement to that. It's not a competition with that. So the structure has to enable us to be able to do these things. And that's where the big challenge is. What do I want to see in 3 years? Well, what I really want to see is all the recommendations in bringing care home are implemented. That means we'd be able to see increased accountability for performance, and we already heard about the Lynn role for that. System and Lynn-specific capacity planning. Defined outcomes in family-centered care. What does it really look like when care? One of the ways it looks like is when a coordinator, case manager, comes in to your family to do an assessment, he or she assesses that whole family. That might be the neighbor and the identified client, that might be the spouse, etc. That we have support for caregivers. When you have a 90-year-old woman looking after her demented 95-year-old spouse, and we think we can come in a couple of times a week and just say, how's it going? That's not good enough. We need a clearly articulated basket of services. People need to know. They need to know, what am I entitled to? What am I not entitled to? Where do I need to find other resources? And how can you help me do all this? And we talked about 3 broad populations. You can divide the populations any way we want, but we see there are a post-acute population, a fair size, a huge size of what sometimes we call the frail elderly, people with chronic disease, etc. management. They're kind of stable, but they're going to be the long-term clients of home and community care. And then we see a much smaller population of people with very complex medical conditions. Often they're congenital, they're birth injuries, etc. And these folks are going to be in the system their whole lives. But mostly, at the end of all of this, in 3 years, I hope, Families need to be able to say, things are better for my family now than they were. I understand what the system can provide. I understand who can help me. I know who to call. I know what I have to do. That we're co-managing, co-designing, and playing together in providing care to whoever we have determined is the so-called client. There needs to be access, and the access for all groups. We did not deal with it in it other than to identify it, but there are a lot of marginalized groups who show up nowhere on the radar. And we need a lot of support for unpaid informal caregivers. The realities are we need to get started. So what needs to happen right away? We need to do something. And that's a collective responsibility. So I'm really looking forward to the discussion. I think the ministry, the minister, the political side, et cetera, have a role to play. We need to see the will and determination there, especially now. We have a very short window. We all vote, so you know how short that window is. So we need to do something immediately. And I really put something in quotes because it can be any initiative that has meaning and identifies to families, to providers, to the public, that all of us have begun to make the change that they can see. That it's not just things we're talking about, it's not just the vision. Here's a change we can see that it's going to make my life better tomorrow, next 12 months, than it was yesterday. That makes the client family experience better. Thanks. I'm looking forward to the discussion.
So next, I'd like to welcome Peter Donnelly. I think the discussion of population health, the potential transformative role of the integration and the alignment of Ontario's public health system with the healthcare system is potentially, for me anyways, one of the most interesting pivot points. I think we use the term population health widely and casually without really fully understanding even what it means. And I think we're very fortunate to have Peter join us today. Thank you.
Well, Josh, thank you, and good morning, everyone. This is a fun panel because sometimes you get panels where there's a setup, right? And people are set up to disagree and, you know, think Republican caucus, right? But this is so much more thoughtful and this is so much more creative. To be honest, I don't think I disagree with anything I've heard so far. I think they've been very thoughtful, constructive comments by people who clearly know their areas very well. But what I want to do is just to add an additional piece to this puzzle, which is a public health perspective. Now, this perspective, as you probably have worked out from the accent by now, is not an exclusively Ontario or indeed Canadian one. It's informed by a career that has involved working in Scotland, in Wales, and for many, many years working with an interesting US organization called the Millbank Memorial Fund, and for many years working with the World Health Organization, both their world headquarters in Geneva and also their regional headquarters in Copenhagen. And what those things have allowed me to do, I suppose, is to assemble a different array of experiences of how systems can work. And reflecting on those and trying to answer as specifically as I can Josh's questions, this would be my contribution. Where do we want to be in 3 years? Well, where I think we want to be is that we want to have created a system where we have the conditions which help people stay healthy. So we want people to be able to walk to work. We would like them to have work to walk to, because one of the best immunizations against chronic disease actually is long-term employment and the income and self-satisfaction that goes with that. We want schools which are equipping our kids with the self-confidence and the resilience that will actually allow them to say no to drugs, to say no to cigarettes, and to limit their alcohol intake. We want to work with municipalities in the way that many of my public health colleagues already do very, very successfully, to create opportunities to continually build health in this province. But when those best efforts fall short, and when people still become unwell, as they will, we want a system that is accessible, timely, integrated, focused around the patient, meeting his or her needs, that is very much based on a primary care model, because let me tell you, there is global consensus that that is the most efficient and effective way to address healthcare needs. But what can public health do to help that integration and to help build this bigger picture? Well, public health traditionally works in 3 domains. I think the first one will actually be really quite well known to many in this audience because of the tragic experience that was SARS. So the first domain of public health is very much around the protection from communicable diseases. And that is something that, frankly, this province does very well. In fact, I would say Ontario does it as well as anyone in the world. Between the efforts of Public Health Ontario and of the colleagues who work in public health units and in our hospital system, we have a very good system for communicable disease control. We are infinitely better placed to tackle the next SARS than we were 10 years ago. The second domain of public health practice is around health promotion. And it's not health promotion in the way that many of us traditionally have thought, simply telling people to drink less and stop smoking and eat more green vegetables. It is all of the other stuff that I talked about before. It's about creating that environment that actually makes it easy to make the healthy choices. And there's been some great work in that area. You see it in many of our leading health boards, many of the leading public health practitioners in this province. They're doing great work. Public Health Ontario itself has contributed to that, often in collaboration with other organizations. I think the work that was done with CAMH is particularly notable. So we also need to contribute that. But then there's a third piece of public health practice, which is related specifically to health services. Now, some of the public health units, many of them indeed actually do provide health services in this province. In some sense, they are the provider of last resort. They step in and do the difficult stuff. So the community dentistry and the sexual health and some of these really otherwise difficult to obtain services. But I'm talking about something wider than that. I'm talking about the use of public health skills to work with colleagues to plan a rational and sustainable health system. It's the applied epidemiology of healthcare provision. And in many parts of the world, that's a very normative function of public health. And I think it could be in this province. And it feels to me that that's where Patients First is beginning to take us. The idea that there would be even closer collaboration between medical officers of health and their teams, between those planning and delivering primary care, between those running the LHINs. And what we've just heard is that that's already in some leading areas beginning to happen. People actually are pushing that forward. So I think that's where we need to be in 3 years, but in the 2 minutes I've got left, let me try and answer the second question, which is, what do we need to see in the next year? Well, I think the first thing we need to do is to look very carefully at what has been already, I think, a rapid but pretty comprehensive consultation process. I have had the privilege of seeing some of the draft responses that are being prepared, and I think people are being constructive and thoughtful about this. I think they are seeing the opportunities, but they're also laying down 1 or 2 specific areas of concern that they feel need to be addressed before things can move forward. So the first thing I would like to see a year from now is that those concerns are addressed. Because remember, folks, that delaying a decision is taking a decision. It's taking a decision to do nothing. And I don't think this province can afford to wait. I actually think we need to begin to move forward. I bore people in my own organization by saying that I came to Public Health Ontario because I think that this province has the potential to have the best public health system in the world. And I say so in an informed way, because it has the right level of population, it has the right level of resources, importantly, it has the right level of intellectual capital. You could say the same about health services. There are some quite outstanding, world-leading examples of excellence in this province. But what we have heard is that there are gaps, that there is a lack of integration, that there is a problem with accessibility, and above all, that those services don't currently always manage to put patients first. So I remain optimistic. I look forward to the discussion and hearing your questions, and I cede the floor to what I agree is the most important voice we're going to hear this morning. Thank you.
So thank you very much to all 4 of our panelists. And now, as I said, and Peter just echoed, probably the most important voice on the stage today is the voice of the patient. Many of you know Crystal well. Very, very involved and a recognized leader both nationally with Patients Canada. Actually, I think I recognize the inaugural and current chair of Patients Canada, Michael Decter, and previous deputy in the audience. And no pressure, Crystal, your board chair's here. And very involved, including on the Premier's Council here in Ontario. So thanks so much for making the time today, and we'd love to hear your thoughts on the panelists' comments and also more broadly on the paper.
Okay. Wow, I'm on. Good job, technical team. That usually is the first issue, is getting the mic on. So I think I'll start by saying that, as Dr. Tepper just said, I wear many, many hats in this system, but I think first and foremost and always, I'm a patient. So I think, for this discussion, that's the most important hat, and I want to approach this beyond all my other hats as a patient first. So, hearing from all of these very, very intellectual comments makes me think about not what does it mean to me, who's a very active patient in the healthcare system, who's been in the healthcare system for all my life, and I will continue to be involved in the healthcare system very regularly for the rest of my life. But what does it mean to the average Ontarian? What does it mean to have access to primary care when you're the average Ontarian? What does the LHIN stand for? When you go up to somebody on Yonge Street and you say, if you have a problem with just your healthcare or navigation, you should call your LHIN. Okay. What does that mean? What does it mean when I go home from the hospital? Whether it's an elderly person or the average Ontarian goes home from the hospital, what does it mean to have home care, to have someone that comes into your house and helps you with very personal things that you probably always done yourself and taken for granted? What does it mean when I love the example when an 18-month-old can't get their immunization because he can't find a doctor. But I will also say, coming as a past immigrant, when I arrived here at 10 years old, my mom got my record, but she didn't know which was what. And luckily, we had a good family doctor that can say, oh yes, she had this, and she's missing this one, and this one, and this one, and this is how we're going to get her up to date. What does all of those things mean to a patient? I think I'll start by a few stories. I'll start with this one with acute care. So I had a friend a few years ago who brought her infant to the local tertiary care center. Actually, it was a specialized pediatric hospital. So she called me, and then she asked me two questions. She says, I'm in the hospital. I need to get my baby into x-ray. I can't find the x-ray department. And I said, well, it's not called the x-ray department. She's like, what do you mean? They need an x-ray. Yes, I realized that. But so when you go look for the sign, look for diagnostic imaging. What? She's like, what? What's diagnostic imaging? I'm like, well, it's everything. Actually, it's nuclear medicine, it's radiation, it's all of those things. But why do you call it? I'm like, don't ask me why. Just look for the sign, okay? And then she actually called me back, and because she brought her infant to sick kids, which I recognize, you know what, because your kid's so young, you probably should go to a specialized tertiary pediatric care facility, which for her was the closest one. She called me and said, gee, that hospital have a lot of pediatricians. Well, yes, it's children's specialized hospital. That's where pediatricians work. Oh, okay. And I'm thinking in my head, do I laugh or do I cry? I don't even know how to respond. So that's my very, very first example. But my own personal example, which is actually biasly, which I think is the most humorous one, is so when I got discharged from the pediatric system, I realized I needed a new primary care physician. The one that I had before was talking about me while I was in the room with my parents. I was like, hi, I can hear you. It's kind of not so nice. But I will also tell you that it took me 3 years to find a family doctor, because one of my favorite encounterments is I saw a physician and their response was, well, I don't do wheelchairs. And I said, well, do you do humans? You know, I looked in the mirror this morning and I kind of looked like one, so I hope I didn't change in the last 2 hours when I was traveling here. So, needless to say, I did not go to them for care, because I am not sure what they might do if they didn't think I was human. So, there's that layer involved. Right? But there's also I have a younger sister who is in her second year of university, and she texts me about almost everything, and then my joke is that you text mom for money, and then you text me for everything else. So she texted me a few days ago, and she said, "How will I get access to a physiotherapist?" And I said, "What did you do? Why do you need a physiotherapist?" She said, "I think I pulled something." And I said, "Okay. Did you book an appointment with like the health care services on campus?" And she's like, "There's healthcare services on campus?" I was like, "Did you miss orientation or did you fall asleep?" But the reality is, I think most 19-year-olds don't go through the handbook, and most people don't go through the handbook, and they don't know what to do. So I'm interested to hear about not only the immediate things that we might do, but what does it mean for us in the future? And what does it mean for the future generations to come? Because it's not, and I know we have a huge aging population right now, and that's important, and we need to respect those who came before us, because if it wasn't for their hard work, we wouldn't be here. But I know this is my bias, but I come from the sector of developmental pediatrics, and I will say, people, I have physicians who regularly come, I go into them, and they're like, "You're not supposed to be in my office." I'm like, "Yeah, but the problem is I'm too old for sick kids. So we need to figure something out so that this conversation can move forward, because if you keep on saying that I'm too old, or you're surprised that I can speak in a full sentence, I'm not confident that I can go to you for my own care." Hey, that's the end of it. As a patient, they're like, "Wow, I'm so impressed, you can speak in a full sentence." Right. And I check for their medical certification on the wall. So I'm excited during the discussion to hear what everybody else had to say. Because I always say, healthcare, every voice is critical to the conversation, to every conversation, because healthcare belongs to, and it affects all of us, all of the time. Thank you.
So at this point, what we'd like to do is actually hear from all of you. And we're actually, as I look out across the crowd, we have a remarkable collection of people from across healthcare, including caregivers and other patients and leaders in the healthcare system, and clinicians from across the variety of sectors that we have. And to start us off with both a couple comments of reflections, but also potentially a question, I don't know, we'll find out, turn it back over to our generous host, Brian. So I think we've got a couple of wandering, roving mics in the audience. And so if you do have a question, so Brian, over to you.
Okay, so this is a brilliantly organized panel, so Joshua and everyone, thank you. First a comment and then a question, which I hope all of you can contribute to. So it was about 5 years ago when Susan Fitzpatrick sponsored a variety of reports on the future of primary care, and then more recently, the work that has just been published or released slowly in drips over the last year. But when we wrote the first reports around primary care governance, we referred to LHINs, or what might ever come after them.
because we weren't sure at the time that we would see LINs into the future. And now we're much more confident that we have LINs. We, in our most recent report, were strongly in support of the role of the LINs. But the LINs were designed for our current system. They are relatively small organizations. They were not designed to be an organizer and a coordinator of all of these services built around the patient. So Gary, you know, you're not going to be surprised by this question. What does the LIN need to look like organizationally in terms of resources, capabilities, governance in the future, and not far into the future, in order to play this critical coordinating function? And then for our panel members, what do you need of the LIN? Because the LIN has to be central. You're all central in all of this, but there has to be a coordinating function. So that's my question.
Thank you, Brian. All right. Gary, without trying to read too deeply into the question, I think it's for you.
I think so too. Is this on?
Yep.
Yeah, this side. Thanks, Brian. I was waiting for that question. You know, this one keeps us awake. It's a challenge. We're moving. I have 34 employees, and we've been doing a lot of process and compliance with our agreement with the ministry and working with our agencies with their accountability agreements and trying to put some programs in place and definitely improve the way healthcare is delivered within the mandate that we have. Moving into this sphere, we're going to be bringing over 450 employees in our LIN alone. And that takes on a whole different leadership style and leadership skills when you have an organization of that size that's distributed across 3 distinct offices in 3 regions with 2 unions. So the structure that we need, and we're currently going through an exercise right now, which is quite interesting, on how to redefine the work that we're currently doing under our existing mandate, and then what type of organization do we need for that future state. And we're doing this with our partners, the CCAC as well, as much as we can. We can't get too close to them right now, but we can have these what-if conversations. Do we need to deliver? And so we're looking at, from the big P planning piece, to separate the planning and the accountability and performance management for the broader system. But then how do we establish leadership roles on integrated care? How do we work with that in the system? Now, we're fortunate in our system, we have a number of our community agencies and acute sites that already have integrated positions to help us go down that route. So we're looking at that piece there on integrated care at the sub-LIN level on how we can assist in the rollout of patients first and how we can help manage the business to make all of the providers successful with the patient's voice being heard. On the other side, we have a significant corporate services structure to put together. Right now, when you look at our 14 CCACs, OA plays a significant role in corporate services or backroom. We have a small shared service organization, and we also have a secretariat. We need to figure out, amongst the 14 of us and with the province, what is enterprise, what should be done centrally to leverage the skills and the resources and the systems, and what needs to be executed locally. So I know a number of my colleagues are going through the same investigation. We're sharing our thinking on this. Our goal is to have at least a structure, a straw man structure established for us to start exchanging ideas on and build on as we go forward. But this is something that keeps us awake because this is a game changer.
Great. So I know that we have a previous LIN CEO who wants to weigh in. But what I know there's a part 2 to your question, Brian, but what I think I do, we've got a lot of hands going up in the audience. So keep your hands high. People will run around with the mics. I noticed Michael was quick off the bat, grabbed a mic. Over to you.
First of all, I work for Crystal. She doesn't work for me.
She said the same thing. That's interesting. Yeah.
But second, I can't imagine assembling in this province a more thoughtful and enlightened panel from the various lenses, and and I can't imagine anyone who is a bigger fan than me about hearing Crystal except Josh is. We're in a competition, and yet it was still an afterthought. If you look at the board up there, it says 4 different lenses, and the patient was an add-on, and we're all guilty of it. We think of the provider community, we think of the managerial community. The first thing I'd say is you're having a gathering, whether it's at the Lynn level or wherever it is, invite patients. They bring a practical, common sense view that gets lost in all of the philosophy. The second thing is, because I'm trying to become more practical myself as I age, Crystal has a terrible time getting to our Patients Canada meetings and getting around this city, as do thousands of others, because the elevators on the TTC are often broken. So here's a very practical request of everyone in this office or in this room. When you get back to your office, send Mayor Tory an email saying, please fix the elevators on the TTC. Crystal and I are going to go see him. He's agreed to it, but he said he needs some public pressure, so let's give him some public pressure on that issue. On the big question, and I lived through this, I believed for a long time when I chaired St. Eliz's board that home care was going to be the great integrator, that it was going to be the thing that made healthcare work. And I say with a lot of sadness that I think what we did with home care was we built another silo. And now we're getting a chance to take that silo, thanks to Gail's report and all of the thoughts, and with leadership from people like Gary, to make something better of it and to make it a real integrator. And I hope we do that. I hope we don't just keep a silo intact for all the wrong reasons, collective bargaining agreements, structure, all of that. It is a huge opportunity, and we need to do it. Thank you.
Camille?
So again, thanks for the panel. I have all faith that you'll do everything you're talking about. In 12 months, there are a few I think is still missing from the conversation. Basic things like cultural competence training of all providers, and not cultural competence that says, I'm a black woman, so therefore I expect this or that. Or I'm often surprised, oh, you speak so well, all of that stuff. So what about just basic cultural competence? What about things like you cannot measure where you can't count? You don't have equity data, you look at the panel, you look at the leadership in all healthcare. Diversity is missing. Equity is missing. So how are we talking about population health when we don't have, public health has some of that basic data, healthcare doesn't. So just in 12 months, are there a few basic things that affect patients, is important to patients, that can get done beyond all the other huge structural stuff that I have faith you'll do anyway, but the patient first pieces that I think are shorter term, much more significant on the front line for the patient. That. And, without talking about all the contracts about home care, and without it's off limit now and not being touched, how are you going to deliver what it is you say you're going to deliver?
Peter?
So I think that's a great practical challenge. So here's what I think we should do in the first year. 2 things. The first thing is, let's take a few very practical problems and try and solve them. And I tell you where I'd start. I'd start with Crystal's stories or any other stories that Crystal and you and your colleagues have. So something that's really practical, that's not theoretical, that doesn't require a change in the law, that doesn't actually require a philosophy. And let's see if we could just solve it and make it better. The reason that's important is it creates a sense of momentum. It gets the system beginning to move forward and gets people believing that change is actually possible. One of the things you learn when you come to this province is that Ontario does things slowly. I got to tell you, folks. Now, I don't know whether it's the legendary Canadian politeness, or whether it's just natural caution, and maybe it's just not wanting to lose hold of the stuff that is good. But change takes a long time. So let's empower change by fixing some easy stuff. More briefly, the second thing, important point you make. We do have some data now on inequalities. We are getting better at understanding the populations that we all seek to serve. But that's not shared around in the way that we need it to be shared around. So we need LHINs and public health to work together to deepen the understanding of their populations. No panel is complete without a Jack Kennedy quote. So to misquote JFK, ask not what your LHINs can do for you, ask what you can do for your LHINs, okay? They've got a tough task. It's very important that we all get alongside them and help them. And one of the ways is by sharing the data we've got.
Great. So I think David I just want to recognize how Peter lives that public health. Every opportunity he gets up out of the sitting, he moves around, exercise, very important. Make your day harder, says Mike Evans. There you go, yep.
So just very, very, very briefly, one of the things that we've learned, we started a project called Health Tapestry, which is a Health Canada funded system where we have volunteers going into the homes. But what has struck me is we're starting to understand what matters to our patients in our community within their context, which is driving how we change the system. And to me, that is the critical part of the conversation. So I'm sure we could, Gary would love to have a LHIN that had a bureaucracy of 4 or 5, you probably actually wouldn't want 400 or 500 people. But the point is that it has to be at the local level, and it's about customer service and developing the social contract between the patients, the providers, and the system, the accountable system, the Ministry of Health. And to echo Peter's words, my worry about patients first, it does not go far enough, and it doesn't empower, if that's the right word, the local clinicians and healthcare providers on the ground.
Great. Mike at the back.
Hi, my name is Alan Grill. I'm a family physician and the lead family physician at the Markham Family Health Team. Family Health Team, for all those people who don't know, it's where you have a group of doctors and other interdisciplinary healthcare professionals working together. So I have one comment and then one question for Dr. Price. So we often don't hear the good stories. I mean, on these panels, we often hear about all the problems and the gaps and the barriers, and I think it's important to talk about them. Your story about your wife coming out of hospital sort of rang a bell for me, because our Family Health Team just started a program called Transitions that we're piloting, where we have a relationship with our hospital. We get notified for every one of our 27,000 patients that gets admitted to that hospital, so we can send somebody in to see how they're doing in hospital, and we can help coordinate their discharge plan, make sure they're followed up either at home by one of our nurses or in our office to make sure that their care needs aren't forgotten when that discharge report takes 30 days to come back. So, I just want to say that I think part of this discussion is let's go out there and find the good stories, the stories that are working, so we don't just recreate situations because of the problems that we think are overwhelming the good stories. My question for you has to do with physician capacity. So we hear a lot about access, and Bob Bell spoke at Breakfast with the Chiefs a couple weeks ago. He said that 94% of Ontarians recognize that they're connected with a family physician. So we have some work to do. There's another 6%. But it's all about access. And yet, I haven't heard yet at all, where is the bar in terms of physician capacity? So take Dr. Tepper up there, CEO of HQO. Somehow he manages to find time to still see patients, which I think is absolutely remarkable, and he's showing great leadership. Some critics might say, well, he's a trained family doctor. He's part of the problem with access. He should be seeing patients 5 days a week and maybe not doing leadership. I'm not one of those people, but am I going to tell Josh Tepper that he needs to spend more time seeing patients? There's doctors in my office that have young children. They want to be there for carpooling some mornings, some afternoons to pick up their kids. Should I tell them to work harder because people can't get in? Our clinic is open 7 days a week. The only day we close early is Fridays, and we're open for urgent care after hours, both on the weekend and evenings. We think we're working at very good capacity, yet all I hear constantly is that we've got to improve access, family teams aren't working efficiently enough, And I think it's a big problem. On top of that, we can't hire a new doctor because there's rules in place where new grads are not allowed to join these existing programs. So my question to you is, who's supposed to measure capacity? How do we communicate that to physicians who already think they're working to capacity? And how do we work together so that we don't alienate physicians who already think that they're maxed out in terms of the patient care they're providing?
Great. Thank you, Alan. I see more clinical hours ahead of me in my life.
Boy. That was a really easy question. Thanks, Alan. No question that there are lots of pockets. Actually, I don't think even it's pockets of excellence. It's a broad system of excellence. Where it breaks down is sometimes around the edges. And our family health team, that would resonate exactly what your system is, would resonate very much with ours. We are lucky that this is the problem with the equitable system. We are lucky, your group is lucky, I'm lucky that we have the resources to provide that kind of care, and we see our patients, we have contact with every one of our hospitalized patients within 24 hours of discharge, except on the weekend where it becomes 48 hours. So that does happen, but we don't have this system broadly across the community. And what our patient care group proposal had to be was that you broaden the access to the allied health professionals broadly across the physician population, and you make it accountable, the groups accountable at the local level, so that you can actually say, yeah, our patients do have access. We don't need to work harder. We perhaps need to work differently, but here it is. Our patients can get in to see us, and that there is access. And so that we can say for our 35,000 or 20,000 patients, whatever the number is, here it is, we can demonstrate that we have that kind of access. I think that's what HQO is working towards, is allowing that access, that data to come broadly across the system. But that if we don't know what we're doing, it's really hard to say, yeah, we're doing a good job. And I would disagree with a lot of the FHT comments in the sense that I think FHTs generally are doing an outstanding job, but it takes time for the teams to develop, it takes time for the systems to develop, and we need to be driven by what the patient experience is.
Great. I think Crystal wants to jump in, and also raise your hand high. I think Matt's got a mic that he's willing to distribute. So raise your hand high, Matt will come around, and then Crystal, you have a comment on this?
Yes, so I was just going to say in terms of patient access, I think one of the things that, that was very loud and clear in the strategy was to inform. Right? So a lot of people think that they need to see the doctor for everything. And doctors are great. They have a lot of knowledge, but also we have allied health professionals. So when I go into the clinic, they're like, do you need to see a doctor? I'm like, no, I need to speak to the pharmacist because I have a medication question and I don't really need the doctor, I need a pharmacist. But people don't know that. People don't know, oh, I can talk to the pharmacist? Yes, and you know what? They're probably a lot more available than the physician who's running between patient and patient and patient. They're sitting there waiting for your prescription. So if you go up to them and say, I have a question, do I need to take this can I take it with food? Do I take it without food? It's a very easy access thing, but people don't know that. So it's about, part of that, it's about education as well.
Absolutely, thank you.
So I'm Adriana Tetley from the Association of Ontario Health Centres. And when Patients First came out, I was extremely excited. And I was excited by the page that talked about health equity, social determinants of health. Talked about Indigenous and Francophone, it named mental health and addictions, immigrants, refugees, and that was it. There were no questions that was named about those populations in that in our report. So when the consultations came out, all of our members participated in both the LHIN-based consultations, the ministry-based consultations, and no one is talking about health equity. And that was my biggest, I think, disappointment to the point today related to the consultations that are happening. We talk about the missing voice of patients. I would say there's a missing voice of diverse viewpoints, the diverse communities that are out there. There's also not a discourse happening that if you're poor and you're living racialized and you're a new immigrant coming to Canada, the type of solutions that you need are different from the general population. And I would really challenge everybody in this room, including the panelists, to start thinking about this. Our report is not going to focus on the 4 questions. Our report is going to focus on where is health equity, where are people in communities, and if we want a sustainable system, we know the research is there, that if we deal with poverty, when you look at the 5%, the 20% most in need, who are using the health system the most, it's usually not because of access to a physician, quite frankly. It's because they're dealing with determinants of health and they don't have the necessary resources they need. So my comment really is about the missing conversation in this debate.
Thank you. Peter, quick comment on that?
I'll happily give a quick comment. Point 1, you should not restrict yourself just to answering the questions in the consultation document. I don't honestly think that was the intention. I think people should feel welcome to comment on any aspect of it. Point 2, sometimes things don't get discussed when people actually agree with them. Okay? Now, sometimes they get less attention than they deserve because they're not necessarily a point of disagreement. We're not talking about disagreement in terms of the importance of achieving equal outcome, let alone equal access. What I think the issue is that we're dealing with a gap in understanding. Now, you clearly are deeply immersed in this, as am I because of my training, as are many of my public health colleagues. And so I can reassure you that what they will bring to the discussion with the LHINs, and I know a lot of the LHINs are already there because I've talked to some of the LHIN people, is an appreciation of the importance of social determinants of health, of understanding the things that materially affect outcomes. And I actually think, although we haven't debated it much today, I actually think that's one of the most important things that could come out of bringing public health and LHINs closer together. So I'm glad you've raised the issue.
Okay. Yep. Oh, sorry, Gail, my apologies.
I just want to add one thing, and it really has to do with, so far this discussion, which I think is very valuable, issues of equity, et cetera, have focused on what the LHINs need to do, what family health teams need to do, et cetera. I think we need to keep in mind that the point of care providers need a lot of help in this area. You know, most of my background has been in education and health education, and I say not proudly that we've done a lousy job of that. And we've done what's been easier, what's been comfortable in terms of what we know and who we are, or who we have been. Now who we are is changing, and it's a big catch-up. Yeah. And I think I'm still very fixed on point of care providers are really the ones who need to be directly engaged and who need a lot of help in addressing these issues, in being comfortable with these issues. It's not about what you know, it's about how you incorporate what you know into your daily practice. So mine is also a plea to those out there who are educating, who have responsibility for frontline point of care providers to provide help in this area. What we want to avoid is a blame game. What we want to do is transform a system to become more sympathetic, more empathetic, and more family-centered. And that means helping people at the point of care know what that looks like.
Crystal?
Okay, so I was just going to touch on Gail's point. And, you know, so every time I go into clinic and if I get a prescription for antibiotics, I look at the doctor and I say, are you supposed to be asking me something else? And they said, no. What? And I said, are you going to ask me if I have food tonight to take with my antibiotics? I'm not saying that I don't have food in the fridge, but I'm saying that, you know, and that to most physicians, it's a very personal question. I'm not going to ask if my patient has food. Well, if they don't have food, they can't really take the antibiotics, and how do you expect them to get better? But I think we need to start looking at how do we teach social determinants of health to our medical students, to our new physicians that are coming out, and being comfortable with saying, I'm going to ask you that question, not only because it's my job, but I genuinely care about your overall health as a holistic individual.
Thanks, Crystal. That's a fantastic point. Reza, I think?
Yeah. Lovely presentation, but as they say, the devil's in the details. So I have 3 brief comments/questions. The first is, if we're going to put a lot more emphasis on the LHINs, how do we deal with care that would span LHIN boundaries? I mean, the Hospital for Sick Children is not just dealing with people from that LHIN. People from ethnocultural communities may be seeking out care in not necessarily where they happen to be in the LHIN, but in a neighboring thing where people understand the culture. And are we going to be putting up a lot of silly barriers to integration of care by focusing on sub-LHINs? My second is, there's a lot of emphasis on integration and coordination, and I agree with it. But how do we deal with the fact that auditors will call that administrative costs and start screaming that you need to have all the resources going to frontline care, because any attempt to do care coordination is considered to be administrative costs and ergo wasteful? And the third, and this is a plug for a special issue of a Longwoods Journal, Healthcare Policy on Accountability. One of the things we found in some reviews is that lots of extremely important things are very hard to measure and or are not controllable by the people being held accountable for them. And what happens is they drop that. So public health, when it's successful, is invisible. And what starts to happen is a focus just on giving particular services and measuring it, and a lot of the things we consider to be super important, including how you get on with your patient, drop out and get lost in the shuffle. So how do we make sure that by doing this, what is measured is what's mattered? We don't leave out the fact that lots of things that are hard to measure still matter a lot.
So what I'm going to do in the interest of time, those are 3 very thoughtful questions, all thesis worthy, recognizing your academic background and tenure. I'm going to just, what we'll do to close this out is I'll ask the panelists, and we'll just start at the end and move through to pick any one aspect of those questions, or simply ignore your question completely and give a final comment at their discretion. So David, we started with you. We'll go back from you.
So I'm going to ignore the questions. It really
Sorry,
is...
Reza.
Thanks for the permission to do that. I think that for me, the biggest issue here is absolutely an equitable system. In Hamilton, for example, you have a almost 25-year life expectancy difference in 5 kilometers. And we know that, so give us the resources. And that always seems to be the plea, is help us, allow us to use the resources within our community to understand our patients, to understand what is important to them, and to figure out how to provide a basket of care.
I love it when you realize there's a 25-year difference, you suddenly leapt to your feet and started moving around again. Gary?
In the spirit of keeping moving, LHIN boundaries, that's a good one. We always heard, and Camille's nodding her head here, for those of you in the GTA, there's a whole different world on the east side of Victoria Park to the west side of Victoria Park. And that's a challenge for the service providers, for the LHINs, and for the patients and their families. So when you get into the GTA or large urban centers, that cross-LHIN program delivery is a challenge that has to continually be worked on. We still have in our LHIN, as you know, our tertiary care is in London. We still have people contacting my office saying, here's a copy of a letter that I received saying that from a hospital in Southwest LHIN, I guess you can guess which one it is. It says, oh, we don't look after anybody that lives in Erie St. Clair. We even get that from county to county still, so it takes a lot of education to improve that. So it's deep with us in thought. With respect to accountability, and I mentioned earlier when I was up at the podium there about when you look at Petrolia, and you want to hold the system accountable. We can get everybody in one room, a lot smaller than this, that are responsible for the delivery of primary care and acute care and post-acute care and community services. We can have everybody at one table with a shared accountability to manage that and to hold them accountable for the outcome of the population, and even hold them for the outcome of specific tactics that we're putting in place. So that's one way of doing it. Break it down to something that's manageable. In Chatham-Kent, 110,000 population, we have 3 family health teams, and we only have 4 sole practitioners. We can get them all in one room with our providers. So I think the Sublin strategy is the way to go.
Gail.
I guess I have to stand up too. So a comment related to what we can't measure. We have a lot of expertise within the system. We have to be careful not to reduce things to what's only measurable. We know from families, we know from public the kinds of expectations they have, and we have to listen to that. A comment raised about coordinators. If I could do one thing, I would make sure coordinators were considered point-of-care providers. The job of the coordinator is to, with the family, plan, deliver, evaluate the care. So I hope we get to that point. They are not managers. They are point-of-care providers.
So keeping moving, because time is short. The 3 great questions, I'm just going to say a little bit about one of them. There's a whole bunch of stuff we can measure in public health, including stuff related to equity, actually. But you're right, that there's a need to think about it very carefully so that that doesn't get lost in a process which measures things which are easier to measure. My closing comment is this: how do we know this isn't another false dawn in the story of healthcare reform in Ontario? Those who've been involved in this province for much longer than I have will know that there have been a series of attempts in the past to reform the health and healthcare system in this province. There's one big reason why I think it's different this time. We're speaking on budget day. This province is highly indebted. Healthcare, the Ministry of Health is the biggest spender by a considerable way in this province. And I used to work for an old-style, Oxford-educated civil servant in the UK, and he had a very plummy voice. And I was bewailing the fact that we didn't have enough resources for something that I wanted to do, and we couldn't get change. And he said, "Young man," he said, "you really must never, never underestimate the value of a good financial crisis." And he had a point. He had a point that sometimes when your back is up against the wall in terms of the money, when things just cannot go on, actually it is the thing that you need to finally leverage change in the interests of patients and in the interests of the population. So that's why I'm optimistic, and that's why I think this time it's different.
But when you read the budget today, rejoice for your zeros. Christo, final comment?
I think I would use the phrase that we use in healthcare, which is cautiously optimistic. I think, if we don't invest in healthcare, in ourselves, in the plan that we hope to achieve, within the 12 months indicators I've already mentioned, in 3 years, and in the future, we will be in a really big crisis. And I hope that by working with all of you in this room and on the panel, and putting not only patients, all of the patients in Ontario first, that we can work at this together. Thank you.
Great, so very appropriate. I would like to once again thank Longwoods, our host Rotman, in case you didn't know, Canada's #1 business school right there. So thank you to Rotman and to Longwoods. And thanks to all of you for coming today. Thank you so much.